Welcome back, everybody, and welcome back to my spectators. Before we begin our discussion, we will go ahead and make sure we're all on the same page. So if you will find your Face the Core page and you have a purple link, go to the discussion. If you open that, you find that both your multiple choice questions, answers, and your performance will be shown. You will see the green answers are the correct answers, and you will also see there's the group performance and those that are. Before we start our discussion, let me set all the links up. Let me remind my all my spectators today, if you would please give both question numbers and case numbers so that your questions can be answered at the end.
Yeah,
Doctor?
I'll go to the discussion part of it. Yeah.
Okay. Do you have everything available to you?
Yeah, yes, I'm going to the discussion part of it. Should I click on that now so that you can see?
Yes, do that now. Yes,
right.
Do that now.
Yep, I did.
All right, whenever you're ready, all yours.
All right. Good afternoon and welcome back for the discussion portion of the Neuro Series 1, Face the Core. Before we start, I want to tell you that by no means the teaching, the points which I'm going to point out in these cases or the points which are given to you at the end of the discussion is complete because of the shortage of time and the limited amount of time that we have. But I will try to highlight on the most important points in each case and we go forward. Case number 1. The question number 1 is regarding the location of the lesion itself, and the location is in the clivus. Clivus is actually a part of the base-sphenoid-base-occipital junction, as you very well know, and it is lying behind the dorsum cell. That's the reason why you see it very well on the sagittal MR sequences rather than CT, and it is also posterior to the sphenoid sinus area, and it is actually right in between the foramen lacerum, through which actually the internal carotid arteries pass through. And this location at the skull base, the clivus, it is a common location for 2 of the primaries, which is the clival chordoma, which is this case, and also chondrosarcoma is another primary. Other than these 2, the more important pathology that you see will be metastasis, usually from lung carcinoma or breast, and for that matter actually any primary which has got a predilection for bone and skull base spread. Then going on to the second question. This is regarding an artifact that we see most often in the posterior fossa. This is the beam hardening artifact, which we see at the junction of the bone and the brain parenchyma. You will see multiple, usually horizontal alternate areas of increased and decreased densities, and that really, makes the findings of the posterior fossa to interpret very difficult, and that is the biggest limitation that you see in these cases of posterior fossa evaluation on CT, and that's where the MR scores over the CT, as you all know. And that's the reason why this very small pontine infarcts can easily be missed or even overdiagnosed in these cases of CT scans. So beam hardening artifact is one important artifact that you almost constantly see in most of the scanners, but the more recent scanners have got some post-processing facilities and software to reduce, if not completely eradicate, these artifacts. That is, then move on to the next question, which is regarding the diagnosis, and in this the common conditions that we have already seen are the chordoma, the metastasis, and the chondrosarcoma. So the pituitary macroadenomas are really not in the differential diagnosis in these cases with these findings at this location of the clivus. And almost all of these lesions produce bony destruction in the clivus and at the skull base with a significant degree of soft tissue component in every one of these pathologies. And of course, the pituitary macroadenomas, they can involve this area, but they're much less commonly seen. And whenever they involve the clivus area, you see that there is more remodeling of the clivus rather than actual fulminant destruction itself. And the pituitary masses in general are mostly anterior to the clivus or the dorsum, and then less often they also extend inferiorly into the sphenoid sinus through the cella floor. In fact, other than these, the secondary involvement of the clivus is even more commonly seen in a nasopharyngeal carcinoma or a sphenoid sinus carcinoma rather than in cases of pituitary macroadenoma. And the next question that we have is as to how to make a diagnosis, or what is the most likely diagnosis in this case. It is more of a differential, but with a bone destruction and a significant degree of enhancement together with soft tissue component which is enhancing on both CT and MR. The chordoma is most likely diagnosis. Of course, it cannot be differentiated very well from a metastasis, which can exactly look in the same. But a typical location of that clival involvement usually points towards a diagnosis of chordoma. But as I said, metastasis can always produce a very similar type of involvement. And coming to the last question on this case, the chordomas, as you very well know, is usually adults. The involvement is in the clivus, but in cases of children, it is at the lower end of the spine, right at the sacrum. It is presenting as a huge soft tissue mass in the presacral area in the pelvis, with again the destruction of the bone being a very predominant finding. So the involvement is at the either end of the spine, upper end clivus in adults and lower end in the sacrum in children. Moving on to the second case. Okay. Moving on to the second case, there is the first question is actually as to the location of this lesion again. The location of this lesion, as you can see from here, it is just anterior to the frontal horns of the lateral ventricle and is crossing the midline, and this is the location of the corpus callosum, and the part of the corpus callosum which is involved here is actually the anterior part of the genu area, and the other portions of the corpus callosum, as you very well know, which are best shown on the MR, will be the rostrum and the body, as well as the posterior splenium. And this genu is also otherwise called as the forceps minor, as opposed to the forceps major, which is more posterior, or the splenial portion of it. And the frontal lobes are actually on either side of this genu of the corpus callosum itself. And the lesions like in this case, a toxoplasmosis, or other lesions like lymphoma as well as GBM, they can all cross across the cerebral hemispheres through the corpus callosum anteriorly through this genu of the corpus callosum itself. And the splenium is the posterior portion which is lying behind the third ventricle, and as we said, that is called also the forceps major. And coming to the next question as to the most likely underlying clinical setting for the condition that is shown, the AIDS is the right answer. And in immunocompromised patients, there are two important conditions that happen which can give you enhancement pattern as well as the morphology like that what you are seeing in this case. The two are the toxoplasmosis and lymphoma, both being common and come secondarily in cases of immunocompromised situations. And of course, the seizures are not really common in these situations unless the cortex is involved. And it is usually seen in cases of any ischemia, trauma, any tumor, anything which involves the cortex can be a focus for the seizures. And the deep-seated lesions are much more commonly associated with neurological deficits rather than the seizures. And of course, the brain lesions can occur with sinus and mastoid disease, but usually you'll see a contiguity with the adjacent sinus to think that this lesion is in contiguity or following the sinus or the mastoid air cells, which is not seen in this particular case. And coming to the third question as to the patient is having HIV/AIDS and he is immunocompromised, and in that situation the more common two conditions which I already enumerated is the lymphoma and toxoplasmosis, and both can cross the midline, both can show a very intense enhancement, and the toxo can have a more heterogeneous enhancement rather than a solid enhancement which you see in lymphoma, but both are possible. And both can be multicentric. There can be multiple lesions in both situations. And one definitive way of differentiating the two would be by a PET scan, where lymphoma will be intensely positive and toxoplasmosis, of course, you do not see any positive findings on PET scan. So those are the two possibilities. And with HIV/AIDS, I think toxoplasma is much more possible. And another reason for that is the multicentricity of the lesion, that you see a second lesion in addition to the big lesion in the right thalamic region, and that multiplicity though can go with lymphoma as well. The toxo would be much more frequently seen. And coming to the fourth question in this case, as to the least helpful in the correct diagnosis, of course, edema is the right answer, because edema is a very non-specific finding, and a vasogenic edema that you see in this case involving predominantly the white matter and going in between the gyri and extensively giving you that spider pattern can be seen both in cases of infective lesions and also as frequently in also neoplasms like primaries or secondary neoplasms. And heterogeneous enhancement that you see in this case is, as opposed to a solid enhancement, would be much more common in toxo, as we have already shown. The rest of them are common in both situations. The multiplicity and the lesion morphology is of course important, and clinical setting of course is also important. But as I said, given the situation, still a lymphoma is a good possibility in these situations of immunocompromised states. And as far as toxoplasmosis is concerned, of course, the seropositivity is not really that helpful because serology is one of the things which is mentioned, but more than I think about 70% of the US population is positive. But in cases where there is a PCR of the blood or CSF, which is a polymerase chain reaction of that, is much more helpful than a simple seropositivity to then make a diagnosis of toxoplasma. And lymphoma will be very much positive on a PET study, and PET will be the most important diagnostic finding that you see in these cases. And as far as the management is concerned, the appropriate management once you come to the diagnosis of toxo is, though you cannot, short of biopsy, you may not be able to prove, but if PET is negative, I think an empirical treatment for toxoplasmosis and a follow-up study is what we need to do. And if it does not show any signs of resolution, maybe you can think of a lymphoma or at that time you can always go and do a PET study to confirm that it is a lymphoma. Moving on to the third case. The first question is about this is as to the possible diagnosis. Here we see that there is a multilobulated, partially separated, very large lesion in the right frontal lobe with a midline shift, and the enhanced study shows a very thin but definitive smooth wall all around it, and the diffusion weighted images show a positively restricted diffusion within the lesion. And with this confluence of all the findings, one can very definitively say that this is a case of a large brain abscess, most probably a pyogenic brain abscess. That is the most likely diagnosis. And neoplasm usually do not have these smooth inner walls. Instead, they will have like a necrotic GBM, which could be in the differential. You should expect a much more irregular inner margins rather than these smooth margins, and the walls will be more eccentrically thickened rather than a uniform enhancement thickening like you see in this particular case. Cerebral lymphoma, again, as I said in the previous case, is you expect a very solid enhancement, but it is very unusual to have so much of necrosis in a lymphoma unless the patient is already on treatment. Even then it will show similar to a necrotic tumor rather than a uniform thin wall like what you see in these cases. And diffusion positivity, of course, as far as lymphoma is concerned, theoretically it is possible that the lymphomas can show positive diffusion, but it is usually the solidly enhancing tumors that you expect to see the diffusion positivity in lymphoma cases. Cerebral hemorrhage, of course, obviously this is not a bleed from the one thing is the diffusion, and secondly the signal changes that you are seeing here doesn't go with a hemorrhage, and especially you have to think of that as a possibility theoretically from the recent onset of headache, which is given as the possible the clinical setting. And in the second question as to, in the case of a cerebral abscess like this, what is the important imaging finding which will suggest the poorest prognosis? It is a lot of things can be important, the size, location of the lesion, like posterior fossa lesions are much more dangerous or can lead to complications and deterioration much earlier than supratentorial. But the most important of them is actually the ependymal enhancement. And ependymal enhancement usually suggests that there is an intraventricular extension of the lesion itself, and an intraventricular extension has got a very poor prognosis. And in general, even with treatment earlier, the prognosis is poor and the mortality rate is almost 50%. And presently, with the good antibiotics and early surgical evacuation of the abscess, still the mortality is pretty high at around 20 to 25%. And the ventricular extension will make the prognosis and the mortality rate much worse than without actual intraventricular extension. So the most important is an ependymal enhancement, though others are also relatively important, as I already pointed out. And in the question 3, the recent onset of headache, which of the following findings is most indicative of the diagnosis? I partly discussed this, the ring enhancement, diffusion, and the edema and mass effect. Of course, restricted diffusion is typical for an abscess, so that would be the most indicative of the diagnosis. And of course, with the conglomeration of findings that you see, that there is a clear fluid inside with restricting diffusion, thin walls, thin smooth inner margins, all these findings together, of course, you will come to a right diagnosis of a cerebral abscess, out of which the diffusion positivity is most important. And in the question number 4, where in this case you can see that there is a developing hydrocephalus with enlargement of the left lateral ventricle. There is a obstruction of the ventricular system right at the level of the right foramen of Monro. And the foramen of Monro lesions, a lot of lesions can produce obstruction, obstructive hydrocephalus changes. Classically, you might have heard of a colloid cyst, and also in cases of tuberous sclerosis, a giant cell astrocytoma. Both are typically located close to the foramen of Monro, causing a progressive hydrocephalic changes. And in this case of cerebral abscess, also there is a similar location involvement and obstructive hydrocephalus that you are seeing here. But the morphology, enhancement, and other findings, none of them suggest anything like a colloid cyst or a giant cell astrocytoma in these cases. And site of obstruction for a hydrocephalus varies depending upon the pathology and location. And in cases of subarachnoid hemorrhage, the site of obstruction for the to produce hydrocephalus will be at the level of the arachnoid villi. And of course, foramen magendi is a fourth ventricular structure, so obviously we are not dealing with that. We are talking about the supratentorial lesion. So the right answer in this case will be the obstruction of Monro is as the site for obstruction in this case of cerebral abscess with hydrocephalus. And the last question in this case will be the what is the best management? Emergent treatment, drainage of abscess, and pre and post-operative, perioperative antibiotic therapy. A very aggressive treatment is the way to go because the mortality rates, as we said, is pretty high. You can't wait to do any other imaging studies, and or a biopsy is of course out of question. PET-CT also is more time consuming, and then that's not really indicated. And the most appropriate step in the management is to do an emergent drainage of the abscess together with the intravenous antibiotics. The fourth question will go, the fourth case is a case of a plasmacytoma of the cranial vault. You can see that at the first go, you see that there is a huge biconvex lesion looking like an epidural lesion that in fact is the right answer for this as to what is the most likely location of this abnormality is a epidural. You see that biconvex or lens-shaped large hyperdensity with a significant mass effect on the underlying brain, and so the location of this lesion is extradural. But if you see very carefully, the underlying bone is showing much destruction. So the epidural hematoma, which can look very much similar, is most unlikely because of the associated bone abnormality that you see. So the location-wise, though the epidural lesions do typically show a biconvexity like this, please remember that a chronic repeated subdural hematomas with some sort of adhesions can produce a false appearance of a biconvex lesion like this, and so a chronic subdural can look and mimic an epidural lesion, but the clinical history would be much more helpful in those cases. And coming to the subarachnoid location, as we all know, it follows the cerebral sulci and the fissures, and within the cisternal spaces when you see the hyperdensities, obviously it is a subarachnoid bleed, and we can't miss that. Coming to the second question, based on the findings, what is the most helpful to examine in this particular case will be the bone windows, which will be the most appropriate, because you can see that you suspect that the underlying bone is not fractured and it is not normal, but it is thinned and very irregularly outlined. And so I would definitely look for a more detailed evaluation of the bones, and I'm looking for actual bone erosions. So the bone windows would be the most appropriate thing next to do, which doesn't need any additional imaging or additional contrast or anything else. So MR, isotope studies, and a contrast enhanced CT, all that can wait. And the first thing that you can do, and the best thing to do, would be to look at the bone windows. Coming to the question number 3, these are the bone windows that you can see that the bone is extremely thinned out and destroyed, and some element of soft tissue element is also seen within the soft tissue scalp, and incidentally has got few radiopaque foreign body densities that are seen within the soft tissues from a very past remote history of a gunshot wound, which has nothing to do with the present problem. So here we have a case where there is bone destruction with soft tissue component predominantly in the extradural compartment, mimicking but not an epidural hematoma, but mimicking an epidural hematoma. So with that finding of a big soft tissue component in the epidural, and more importantly the bone lesion, the most appropriate would be a destructive lesion. And the two important things one has to consider will be the metastasis, and the second one is an osteomyelitis, though osteomyelitis of the scalp and the underlying bone, of the bone with the scalp involvement, is not that frequently seen, but it is possible. And much more frequent is a metastatic lesion like what we have seen in this particular case. It turned out to be metastasis. Of course, a meningioma is a possibility, but underlying bone will not be destroyed in meningioma, and instead it will either be normal, or there can be a blistering effect or a sclerosis of the bone itself as opposed to destruction. So meningioma would be very unlikely in this case. And of course, osteomyelitis, to consider a clinical history would be most appropriate, and that will give you a clue as to whether it is infection is there, together with the clinical findings. And the fourth question is, what is the next step that you would like to do in this particular case? Do you want to biopsy or do a PET CT, or do you want to do a lumbar puncture to see how the CSF is? And the right answer will be to biopsy this lesion. The biopsy will, because the primary suspicion is the two things, either an osteomyelitis or a metastatic lesion or a neoplasm lesion like a metastasis. So the biopsy would be the most appropriate in addition to clinical correlation with the history. Lumbar puncture would be least helpful in these cases. And coming to the fifth question, as to herniation or types of herniation in cases where there is a big space occupying lesion intracranially, whether it is infra or supratentorially, there are different types of herniations that are described, and of which the uncal and subfalcian herniations are supratentorial, and the tonsillar herniation, either superior or inferior, that will be infratentorial. And of all, the subfalcian herniation is the commonest, and of course at the same time has got, fortunately, least dangerous, but however they can produce a significant effect on the anterior cerebral arteries, producing infarcts. And uncal herniation, of course, is transtentorial, and it can result in a third nerve palsy, and it can also sometimes, because of the compression of the crus cerebri, it can produce an ipsilateral hemiparesis, and sometimes due to the compression against the tentorial margins, there can be small hemorrhages within the brainstem or the pons, upper brainstem or the pons, and that's what you call them, the Duret's hemorrhages. And the tonsillar herniation, of course, is coning of the cerebellar tonsils through the foramen magnum inferiorly, just like what you see in Chiari malformations. It occurs also acutely and causes compression on the brainstem and cardiorespiratory failure, and that is a common cause for death if there is a large mass effect or hydrocephalus, and especially in those cases if you go and do a lumbar puncture, as you very well know, is contraindicated. That is the important complication that you expect to find. Moving on to case number 5. This is a large infratentorial mass, which is shown here as hyperintense on T2 weighted images, and on the contrast images it shows that there is barely any enhancement except this little increased signal intensity along the periphery. It is probably because of the compression of the adjacent parenchyma. A lot of times it is very difficult to differentiate whether the lesion is extra or intraaxial within the posterior fossa, especially when the lesion is very large, like in this case. But a definite and clear margins of the lesion from the adjacent brain parenchyma usually suggest that this is a extraaxial, and so that capsule demonstration gives you a clue whether this is intra or extraaxial. Presence of that capsule suggests that it is an extraaxial mass. And also it can show some sort of a white matter buckling, which is seen, as opposed to a white matter effacement, which you see in cases of intraaxial masses. But as I said, like in this case where the lesion is very large, it sometimes can be pretty difficult to differentiate extra and intraaxial lesions in the posterior fossa. Effect on the fourth ventricle itself is very common in a large lesion, and that in no way differentiates the location of the lesion, whether it is from within the parenchyma or outside. And coming to the second question in this case, based on the findings, what should not be included in the differential? So the possibilities of a non-enhancing large T2 hyperintense mass, extraaxial mass in the posterior fossa, the differential diagnosis of course includes the two important ones, is the epidermoid and the arachnoid cyst. Both are cystic in nature, and both do not enhance. And of course cholesterol granuloma can extend into the posterior fossa like this, huge, and that also is a non-enhancing lesion, and it can be bright on T2, and it can also be bright sometimes on T1. But schwannoma should not be included simply because of the absence of enhancement in this case. And all schwannomas without exception do enhance pretty intensely with gadolinium contrast. They can of course cause a lot of cystic degeneration, but enhancement, positive enhancement, is a typical feature for all schwannomas, which is also one of the common findings or common masses within the posterior fossa extraaxially. And moving on to the third question, out of the two, epidermoid or the arachnoid cyst, which is the most likely diagnosis in this particular case, is basically decided on this image, which is a diffusion weighted images showing a positive and a true restricted diffusion, and epidermoid very classically shows restricted diffusion. Arachnoid cyst never shows a restricted diffusion. Other than this, the other important finding that you normally see in cases of epidermoids is, as opposed to an arachnoid cyst, is that the internal architecture of the lesion itself, even if you don't have the diffusion weighted images, if you see the internal architecture, there will be a partial septations and some signal intensities within the lesion. It is not a 100% pure cystic lesion like an arachnoid, and that what they describe as a dirty cystic lesion. And those internal septations will give you a clue that it is most likely an epidermoid. Of course, DWI will confirm your diagnosis. So this case is an epidermoid showing a positive restricted diffusion that you can all see. Coming to the management as to what is the next appropriate step in this case, I would say that surgical resection, it is not an emergency procedure unless it is causing an obstructive hydrocephalus, but this is a very, very slow growing lesion going over for years, and surgical resection is important to prevent any future involvement of cranial nerve palsies or hydrocephalus or compression over the brainstem itself, and they are not radiosensitive, so usually radiation will be totally useless. It's not emergency, so you cannot leave it alone, but you have to do a surgical resection at some point of time to avoid future complications of cranial nerve palsies or hydro. And coming to the fifth question is a question of anatomy. Sorry. As to what is the structure which is shown. This is a midline structure that you are seeing here. which is a pillar-like structure, and it is obviously a vermis, and which has got a superior portion and an inferior portion. In the axial planes, the other slides will show you the inferior and superior portion of this cerebellar vermis. And the absence of it or dysgenesis of this, you know very well that it can cause a huge spectrum of diseases, what is called as a Dandy-Walker syndrome. And this cerebellum itself has got a very small anterior and a large posterior lobes, and which are divided by a primary fissure, and the vermis is in the midline between these two cerebellar hemispheres. The cerebellar tonsils, what we call, which we see herniating down in cases of Chiari malformations or as a normal variants also, are the inferior extensions of the so-called big posterior lobes of the cerebellum. And the inferiorly, there is also a lateral flocculus and a midline nodulus, which are all parts of the posterior lobe. So these are the structures or the anatomy of the cerebellum itself: an anterior posterior lobe, cerebellar tonsil, a flocculus and nodulus more inferiorly. Those are the structures that you expect to see. Coming on to the sixth case. This is the first question is as to which of the following is the intraorbital abnormality. What is the most important abnormality who has presented with proptosis? There is a right-sided proptosis, and in this image you can see that there is a very dilated large vessel going superior to the optic nerve from medial to lateral, and this is the superior ophthalmic vein, and the location of that and also the morphology of that structure we should tell you that this is a superior ophthalmic vein. And compared to the other side, or even otherwise, if you have seen good number of orbits, you all know that this is much more prominent than expected, and this is a superior ophthalmic vein which is dilated. And the second question is, when do you call a proptosis? A proptosis is when more than 2/3 of the globe is anterior to the line which is drawn from that lateral anterior portion of the lateral wall and the anteriormost point of the medial wall of the orbit. If you draw an imaginary line and more than 2/3 lies in front of it, and then that is definitely a proptosis, 2/3 or more. And in this case, you can see that there is a unilateral proptosis and with a dilated SOV due to a paracellular lesion, which ultimately turned out to be a carotid cavernous fistula. So as I was telling, the other lesion that you see other than the orbital abnormality is this enhancing lesion in the right paracellular area with a very bulging lateral wall and a very uniform enhancement within the area of the cavernous sinus itself. So the correct answer as to what is the location of the intracranial abnormality, it is the cavernous sinus, because of the location that it is paracellular and within the middle cranial fossa, that is the site of the cavernous sinus that you are seeing. And the abnormality is normally the left wall, as you see, it is more straightforward or a more convex medially compared to a convexity laterally on the right side. That is the abnormality. So the right cavernous sinus is abnormal in this case. Moving on to the third question as to what is the diagnosis. The combination of a cavernous sinus uniform enhancement with proptosis and SOV will tell you that this is a case of a carotid cavernous sinus fistula as opposed to a cavernous sinus thrombosis. In the case of thrombosis, you do not expect to find such an enhancement. But paracellular meningiomas or schwannomas or tumors can also enhance, but they do not cause a proptosis and a dilated SOV like what you are seeing. So the most appropriate diagnosis would be a carotid cavernous fistula. Moving on to the fourth question as to which of the following structures is shown by the arrow. As we can see here, This is the opposite side. An angiogram is done, and you can see the carotid cavernous fistula filling the entire cavernous sinus, and through the intercavernous communications, the opposite cavernous sinus is also filling and then draining through the left inferior petrosal sinus, which is the outlet of the cavernous sinus itself, to drain ultimately into the internal jugular vein. So that is the inferior petrosal sinus that is being shown on this particular image. And then the last question on this case is most important acute complication in a CC fistula which is untreated. The two important complications that you normally expect would be an intracranial hemorrhage because of an increased pressure and a backflow, and because of the increased pressure within the cavernous sinus, the cortical veins, some of them which drain into that, the pressure in that will increase, and that can rupture and cause hemorrhage. And the second one is a sudden loss of vision because of increased intraorbital pressure and pressure over the and congestion causing pressure over the optic nerve and vision loss. Those are the two important, of which the sudden loss of vision is the most important acute complication in these cases of carotid CC fistula, carotid cavernous fistula. Moving on to the seventh case, the first question is to what are the following MR sequences used? Which of the following MR sequences has been used to acquire image B? This is a flare sequence. This is a fluid attenuated inversion recovery sequence, and the way to differentiate that from a T1 weighted image, which looks like a T1 weighted image, which is the first one, is the signal intensity of the white matter itself. If it is bright, it will be a T1, and if it is dark, just like a T2 weighted image, then it is a flare sequence, because the ventricles, the high signal of the fluid is attenuated. That is what it is, a flare sequence. So a fluid attenuated inversion recovery sequence is usually T2 weighted, but some people do a T1 weighted flare sequence also to increase the contrast within the image, but that is much less commonly used compared to the regular flare sequence which you are seeing here, which is very similar to T2 except that the fluid is attenuated. And the second question in this is which of the following findings is an indicator of remote hemorrhage? That is a low signal intensity on T1 and T2 weighted images that you can see along the periphery of that lesion, which is the hemosiderin deposition along the periphery, which is a classical, which is best shown on the, of course, the GRE sequences, and that is an indicator of a prior bleed and the blood degradation products, of which the hemosiderin never leaves the brain, and that gets deposited along the periphery of the lesion itself. So that is the hemosiderin. Coming to the third question, the most likely diagnosis in this case, of course, is cavernous hemangioma. Capillary hemangiomas are not seen intracranially. They are over the face or overlying the orbital region rather than intracranial. Oligodendrogliomas, of course, are more frontal lobe lesions. This is also very close to the frontal lobe, is in the frontal lobe. But oligodendrogliomas are do not bleed. They can calcify, and they are frontal. They can be very cortical in location as opposed to a deep location, what you are seeing in this particular case. And sometimes even the crossing of midline is seen in cases of oligodendrogliomas. So this is a cavernous hemangiomas case, which is shows this popcorn type of appearance, and on enhancement patterns you will not see much of enhancement, very minimal or none. And if you see the periphery of the lesion, it usually has subclinical small bleeds, which will result in hemosiderin deposition around the periphery. So this is all the features of the popcorn appearance. Not much of mass effect because this is a very slow growing lesion, hemosiderin ring, which will all tell you that this is a cavernous hemangioma. But the cavernous hemangiomas a lot of times can be associated with DVAs or developmental venous anomalies, which you can see only on a post-contrast image in this case. But unlike cavernous hemangiomas, they never bleed. They are developmental venous anomalies, which are the normal venous channels of that particular part of the brain, and should not be treated by any means and should be left alone, as opposed to cavernous hemangiomas, which sometimes need surgical resection because of the presentation of intractable seizures. They may ultimately go for surgery in few cases. And seizures, because of that subclinical bleed, is the most common presentation in cases of cavernous hemangiomas. Neurological deficits on and off whenever it bleeds can sometimes happen, but that is when it mimics a multiple sclerosis, but it is very much less common. And acute subarachnoid bleed is not usually a presentation in cases of cavernous hemangiomas. And we already talked about it as to how to manage these cases. Most of the cases are left alone because it's the seizure management by medical conservative management that they do. Rarely they need to go and resect, but the complications with resection will be sometimes even more than the seizure problem. And embolization has no role, and of course biopsy is definitely no role in these cases. Moving to case number 8. This is a large midline enhancing mass in the posterior part of the base of the tongue, as you can see, and incidentally also has got a lymph node mass on the right side. This finding was very incidental in this case, and the location of this lesion, as I described, is posterior and in the midline, posterior to the base of the tongue itself. And the location of that, together with a finding of absence of the normal thyroid tissue in the pretracheal area, gives you a diagnosis of lingual thyroid. The other lesions which can happen theoretically at this location will be squamous cell carcinoma, but they do not enhance this intensely, almost like a vascular enhancement. And adenosystic carcinomas are the small salivary gland tumors, malignant tumors. Again, the size of the lesion is too big for it. Even the enhancement pattern is too much for a malignant tumor of the salivary glands. Metastasis to this location is very unusual. And lingual artery aneurysms, yes, theoretically sometimes you can find. And of all the lesions, the most likely diagnosed and most frequently seen will be an ectopic thyroid. In this case, what you call it as a lingual thyroid will be the most likely diagnosis. And what is the next thing that you would like to see if you see a big mass like this at the base of the tongue is to look for the infrahyoid pretracheal area where you normally expect to see the thyroid. That will be absent because when the thyroid is undescended, the entire thyroid tissue remains right at the foramen cecum where it starts at the base of the tongue, and that's what you are seeing here. So in these cases, you do expect that there will be no thyroid tissue in the normal expected pretracheal area like what you see. So these images are showing the normal anatomy of the lower neck, but absence of thyroid gland in the pretracheal area throughout. So absence of thyroid gland is the most appropriate thing that you expect to see. And what is the structure, or what is the inferior end of this thyroglossal duct through which actually the lingual thyroid descends down is the pyramidal lobe, which is part of the isthmus of the thyroid, just to the left of the midline, a pyramidal shaped structure that we call it as a pyramidal lobe, that is nothing but a pulled up isthmus which takes the shape of a triangle or a pyramid, and that's why you call it a pyramidal lobe. It's a false lobe, it's a pseudo lobe, not a true lobe at all. Moving on to the 9th question, and this is the diffusion weighted images. And what is a true restricted diffusion? The typical combination that you might like to see will be that there is a trace images, a high signal intensity, and a correspondingly low signal on the ADC map. And in these cases, whenever there is a T2 shine through artifact, then you do not see this ADC low, but ADC will be high, which will be the both high signal both on the trace images as well as ADC map. That's what you expect to see in cases of a T2 shine through artifacts. Those are the two important differentials that you need to consider whenever you see a high signal on the trace images. Is it a true restricted diffusion or is it an artifact because of the T2 signal shining through even with the maximal diffusion gradients that are applied? Because all the diffusion gradient images as such have two components, a T2 component and a diffusion data. As you increase the diffusion gradient strength, or what is called as a B value, the component which is given by the T2 gets reduced and only the diffusion map or diffusion data shows through much more. But at the background there is always some element of T2 element which is left behind in every image of this diffusion. So that's why you want to always look at the maximal diffusion gradient images to look for true diffusion. And when you see an image like this on the maximal diffusion strengths, then it should also show a corresponding drop. Then only you can call that this is a true diffusion. But if it remains bright, then that is a T2 shine through artifact. And of course, diffusion positive cases or conditions are many. Typical is of course stroke, everybody knows, but that is not the only lesion. We already have seen two lesions before which are also positive on diffusion. One is an epidermoid, classical diffusion positive, and the other one is an abscess, again a typical diffusion positive. Some of the tumors can also be positive on diffusion, and of which the two important ones are the meningioma because of the increased fibrous content and less fluid that can show, and lymphoma because of a very high cellular component in lymphoma. They are all tightly packed, cell volume is there, and because of that also the restricted diffusion will be seen in lymphomas. So the tumors, those are the two important ones. Rarely people have described in metastasis, multiple sclerosis, but those are not that important. So the one which will not show or not expected to show diffusion in this list would be a GBM. So that is not supposed to show any restricted diffusion. Some of the lesions are showing a peripheral rim of small diffusion restriction, but that's not really significant or diagnostic in these cases. And then the question is, based on whatever is given, like the diffusion images and also the T1, T2 weighted images, least likely diagnosis based on the images would be a cerebral metastasis. All others are epidermoid, arachnoid, cyst, can be extradural, meningioma is extradural, cerebral metastasis intracranial or parenchymal, and this obviously is from the sharp margin of the lesion that you are seeing. This is a definite extra-axial mass with positive restriction, so cerebral metastasis is definitely out of the differential, but you can always consider other extra-axial lesions as a possible in the possible differential. So coming to the fourth question as to what is the structure which is shown here in the midline on the coronal images superiorly near the vertex, that is enhancing in the midline, almost a triangular shaped enhancing structure, that is the superior sagittal sinus, and the dural tail which is coming from this extraaxial enhancing mass is pretty close to that coming, and the tumor margins itself have got a clear demarcation from that sagittal sinus and well away from the sinus itself, which is an important finding for the surgeons, because if these lesions are parasagittal, more parasagittal than what you are seeing, and it is along abutting the fox itself, parafalcian meningiomas, with involvement of the sinus, and that is an important finding, because if the sinus is involved and there is complete occlusion, the surgeon would not mind taking the tumor completely together with that segment of the sinus which is thrombosed anyway. But if there is patency of that superior sagittal sinus, they will try to retain the superior sagittal sinus, and it is very difficult to peel away the tumor from the walls of the sinus itself if it is involved. So a small segment or a small piece of the tumor is left behind and will be tackled later on postoperatively by radiation or just a simple follow-up. That is the importance of identifying the relation and the patency of the superior sagittal sinus, which is shown in this case. And coming to the fifth question as to which of the following is the most likely diagnosis. Of course, an extraaxial mass with a enhancement along the cerebral convexity with a dural tail. All the features go highly with meningioma, and which we said some of them can show positive restricted diffusion, like in this case. So this is a convexity meningioma. Epidermoids and arachnoid cysts, we have seen that they do not enhance. And tumor from the skull inner table, this is really not involving the inner table of the skull, but it is a dural attachment of that is shown by the dural tail. So this is a dural-based enhancing mass. The commonest is, of course, we know is a meningioma. Let's move on to the case number 10. This is a very large mass, very aggressive-looking calcified lesion, which you see on the CT. Intense enhancement, extensive involvement causing hydrocephalus, dilated lateral ventricles, dilated third ventricle, and the location of the lesion itself is posterior to the third ventricle in the midline. And any structure which is posterior to the third ventricle, which is a structure between the two thalami, as you know, it's a midline structure. And posterior to that, the structures which are usually seen are the pineal gland, the splenium of the corpus callosum. Those are the two important things that you should remember as far as the location is concerned. The aqueduct of Sylvius is a little anterior to the pineal gland itself, and any pineal lesion usually obstructs the aqueduct of Sylvius, the communication between the third and fourth ventricles, causing hydrocephalus involving the third as well as the lateral ventricles, like what you see in this particular case. And the pineal lesions are usually the tumors which can come from either the primary pineal parenchyma itself or the germ cells. So pinealocytomas, blastomas, or germ cell tumors, they can all be in this location. And because of the corpus callosum or the splenium being there in the same area, a glioblastoma also is a possibility, and rarely a lymphoma, and sometimes much more rare will be metastasis in this location. But in a case where this patient is a young patient in the second decade of his life, a male, then the appropriate diagnosis or likely diagnosis would be a pineal tumor, of which fortunately more common will be actually a germ cell tumors or a germinoma or a teratoma, and much less common compared to germ cell tumors will be a primary parenchymal pinealoblastoma or cytoma, which have relatively worse prognosis than a germ cell tumor. And from the aggressive nature of this tumor, which we have said, it is likely to be a parenchymal tumor, pineal parenchymal, like a pinealoblastoma or a pinealocytoma. And I think this patient turned out to be a pinealoblastoma in this case. The choroid plexus from the third ventricle can also produce tumors like an ependymomas or a choroid plexus carcinomas, but those are much more common in the fourth ventricle rather than in the third ventricle, and they are usually seen in a much younger age group of patients, like children under the age of 2 or 3 years old. And brainstem gliomas, some of the brainstem tumors can be very aggressive, and then they can also produce exophytic component which can look and mimic a tumor like this. But most of the brainstem tumors seen again in the younger patients, but not as young as 15, but more of a 20 to 30-year-old age group or 20 to 40-year-old age group patients, they are non-enhancing. This is showing a very intense enhancement, and most of the brainstem tumors are either non-enhancing or minimally enhancing rather than this much of enhancement. Of course, vermis, again, this is more supratentorial. Vermis is a structure which we said is between the cerebellar hemisphere, so it is infratentorial. So vermian tumors would be very unlikely in this case. So the most likely diagnosis is a pineal tumor, and an aggressive tumor like a pinealoblastoma or a cytoma would be the important. How to differentiate the tumors of germ cell origin from a primary pineal tumors? One indication is the location of the pineal calcifications. If the calcifications are blasted out from the center of the tumor itself, or the gland itself, to the periphery of the lesion, it is likely coming from a pineal parenchyma. This is a relative a point to differentiate the two, but it helps quite a lot of times. Like in this case, you see that this is the epicenter of the mass, and the whole calcification is thrown out to the periphery. And in cases of germ cell tumors, the exact opposite happens, that the tumor is there and the whole calcification is buried right in the middle of the tumor itself. So presence of calcification, or the way it is distributed, can give you a very good idea as to whether it is a germ cell tumor or a primary pineal parenchymal tumor. In this case, this is a peripheral distribution of the calcification that you are seeing. And the important complications that these patients will have is, of course, hydrocephalus, because of the proximity of the lesion of the pineal gland to the aqueduct of Sylvius, which we mentioned. And most of these patients actually come with the signs and symptoms initially, and they present with hydrocephalus, with headaches. And when you see there is a big mass right in the posterior third ventricle region, in the region of the pineal gland. So hydrocephalus is the most important complication, as well as the most frequent presentation that these patients will come with. And that's the reason why these patients are initially treated for the hydrocephalus. You shunt them, you decompress the ventricles, and then try to attack the primary tumor by radiation or chemotherapy. And after the initial radiation chemo, the surgeon can go in and resect the residual tumor, and with the shunt there in place for a quite long time until the end of the whole therapy. So the most important and appropriate step in the management of these patients before any definitive treatment of the tumor itself is instituted is to do a decompression of the ventricles. All right, we will move on to case number 11. This is a young patient, and the lesion is in the midline like the previous one, but this is supratentorial like the previous one, but this is much more anterior, or more or less in the center of the lesion, and you are seeing a level well above the third ventricle region. So it is much more supratentorial than the previous one, and it shows a predominant cystic nature of the lesion, with some specks of calcification along the wall, on the left wall of it, and on the post contrast there is no enhancement that you see. So the location of the lesion here is supracellular. So the supracellular masses, you know very well the differential diagnosis of all the supracellular masses, and if given the supracellular mass and a cystic nature with calcification, and if I tell you that this patient is a young patient, about 6 or 7 year old, the first and the foremost thing that one has to think will be a craniopharyngioma. Craniopharyngiomas are very common in age groups which are between 5 and 15, and again they are very common at a later age, around 40 to 45 years old. So this has got a bimodal presentation, but if it is a child, the craniopharyngioma is likely or more likely to be more cystic in nature, like in this case. And if it is a craniopharyngioma occurring in older patients, you expect that this is a more solid papillary variety that you normally see. So the calcification is typical in craniopharyngioma. Cystic nature, of course, is classical. It is typically, even in children, the description is that it is a mixed type of cystic and solid. but sometimes the cystic component can predominate, like in this case, and with very little enhancing solid component. But calcification and the location, supracellular, and typically, in fact, if you see an MR, it would be supracellular and retrocellular. It is above and behind the cellular. That's the classical location of a craniopharyngioma that you see. So this is a case of a craniopharyngioma, unlike a pituitary macroadenoma, which are not that cystic. They do not calcify. Cystic metastasis theoretically can go, but there are very few such purely cystic masses that you see in metastatic pathology. You do see necrotic metastasis, but pure cystic metastasis is very rare. And a colloid cyst is a good possibility because of the location of the lesion and presence of hydrocephalus, anterior third ventricle cystic mass, but they do not calcify. Of course, like in this case, they do not enhance, but calcification goes against a colloid cyst. So the likely possibility in this patient of this supracellular cystic mass with calcification in a young patient is a craniopharyngioma. And as I said, wall calcification is very important, and that is diagnostic together with the age of presentation. And going on to the question number 4, we talked about it, the bimodal presentation of the craniopharyngioma. The other age group which is involved is around 40s. 40 to 45 is the second peak that happens in craniopharyngioma, other than 5 to 15, which is much more frequent than the 40 to 45. And coming to the 5th question in this, again, which we already talked about, the adult variety of craniopharyngioma is more solid, or what is called as a papillary variety, which is not seen in cases of children. So histologically they are little different, and based on that, morphologically also, the cystic nature of these adult tumors are much less frequent, and they are predominantly solid lesions that you see. But the location-wise, it is the same. And sometimes you may be not, it is very difficult to make and come to a diagnosis of a craniopharyngioma for a supracellular mass in an older patient because the differential, again, you will think more of other tumors like a germinoma, metastasis, meningioma, which are all enhancing solid masses rather than craniopharyngioma, but that is also should be included in the differential in those cases. Moving on to case number 12. Which of the following is the finding present in this case which needs immediate attention? So obviously the hyperdensities that you are seeing abnormally within the ventricles and along the cisternal spaces, right in the interpeduncular cistern here, supracellular cistern, they're all showing hyperdensities of blood. So this is a subarachnoid bleed, which is an emergency, and you should know what is the cause. In the absence of trauma, we all know that subarachnoid bleed, the commonest cause is a rupture of an aneurysm. But that is not the only emergent situation where a subarachnoid bleed is seen in non-traumatic patients. You should always also remember other causes like dissections. And of course, hydrocephalus is a complication of subarachnoid bleed with the obstruction by the blood at the arachnoid villi, which we talked about in the earlier cases. And cerebellar infarct, which is seen in this patient. In the right cerebellum, you see this large low density lesion, which is likely to be an infarct. That is doesn't need the immediate attention compared to the subarachnoid bleed, which probably is the primary pathology in this case, which needs to be evaluated. And how do we evaluate? What is the next appropriate step in this case is to do an emergency CTA. That is the fastest, quickest way of finding out if there is an aneurysm intracranially which has ruptured and which could be the cause for the subarachnoid hemorrhage. And the hydrocephalus mechanism in subarachnoid hemorrhage, we already talked. It is due to the obstruction of the arachnoid villi. At that villi level, there is a communicating type of hydrocephalus that ensues following a subarachnoid hemorrhage. And the next appropriate step we talked about would be a CT angiography. In the past, before the CTA is that frequently done, most of these patients used to go for a definitive catheter angiography, which is still a gold standard, especially if the pathology, underlying pathology is an aneurysm. But nowadays, I think the most appropriate immediate imaging investigations that you would look for would be a CTA of the neck and head and neck, mainly the intracranial circle of Willis to look for aneurysms. Then this is an angiogram, a vertebral angiogram done from the right side, shows that there is a complete obstruction of the flow beyond the distal vertebral artery on the right side, and you do not see any significant flow within the basilar or the branches of the basilar. Very, very small amount, probably just trickles, but nothing significant. And this is a very long, narrow segment, and in the middle of that you can see that extravasation, a small bubble-like appearance or an aneurysmal ballooning of that segment, what they call it as a pearl sign, and this is called the string and pearl sign, which is typical for a dissection, and in this case involving the distal vertebral artery, is almost involving the portion which is intracranial beyond the foramen of magnum, and so that is the V4 segment is the segment which is involved in this case. And whenever the vertebral artery dissects within the portion which is intradural, that is when it can cause subarachnoid hemorrhage. Otherwise, vertebral dissection is very common in C1, C2 segment, where it runs horizontally here and vertically. This is the C1, C2 junction. That segment is the much more frequently involved segment for a vertebral artery dissection, which could be spontaneous, which can be traumatic. In both cases, the more frequently involved segment is that, but wherever the dissection extends or primarily involves that component, the V4, which is intradural, then it can cause subarachnoid hemorrhage. But otherwise, the subarachnoid hemorrhage, non-traumatic, as we said, commonest cause is, of course, an aneurysm. But in this case, the angio shows that this is a typical string and pearl sign of the distal vertebral artery on the right side. And coming to the last question in this case as to how do you treat these patients. Surgically, it is a very limited, very rare, or you do not do any dilatation or stenting. It's pretty rare to do that. The standard treatment for any dissection would be to put on anticoagulants and to prevent the extension of the intraluminal clot. Sometimes it could be controversial that in the presence of a subarachnoid hemorrhage, do you want to give anticoagulants? But that is still the definitive treatment, especially when you find that you want to prevent the extension of that intraluminal clot. You just give an anticoagulant therapy. And the thrombolysis, again, if it is a complete occlusion like this case, and the collaterals are very poor, especially the V4 segment, that is very poor collaterals. The cervical portion of the vertebrals, when it is occluded or stenosed, they do take up a lot of collaterals from the neck muscular vessels, but in the V4 segment, the collaterals will be poor. In those cases, some of these patients can be subjected for thrombolysis, especially if there is left vertebral artery is not the dominant one and is not able to compensate for the flow within the basilar, then maybe thrombolysis can be attempted. But standard treatment would be in a dissection to give anticoagulants. This is a case number 13, where you see that the lesion is right in the skull base at the jugular foramen level, where there is it is not only enlarged, the walls are very irregular and eroded, and it is in the region of the jugular foramen. The jugular foramen is at the skull base itself and posterior to the carotid canal within the petrous temporal bone. This is the carotid canal area which you're seeing, and it is posterior to that, and it is within the petrostemporal bone at the skull base, more medially or posteromedially, postero-inferomedially, and that's the jugular fossa, which has got the two components: the anterior neural compartment, which where the 9th, 10th, and 11th nerves pass through, and a more posterior vascular compartment where actually the internal jugular vein sits. So those are the two important components of that, and the lesion in this is involving by location the jugular foramen. And coming to the next question is as to which of the following is represented by the dark spots in the lesion. I think it is coming on this one. You can see that these are multiple spots which you are seeing. These are the blood vessels running through the enhancing tumor tissue, which is stationed within the jugular fossa region, and that classical dilated big large vessels within the tumor gives you what they call the salt and pepper appearance, which is typical for a glomus jugular tumor. So the glomus tumor has the very vascular tumor, and that causes this salt and pepper appearance. So what you are seeing is all blood vessels. Cystic changes and calcifications can look very much similar to that, no doubt, because they also drop signal, and in the cystic changes on T2, or at least it should show fluid signal. We don't show the T2 weighted images here, but with a big enhancing mass and then these flow voids within the lesion, those are all blood vessels due to increased tumor vascularity. And the unlikely diagnosis would be when you discuss what are the possible diagnoses in this location. The tumors that happen are, one is a glomus tumor, another is a schwannoma. Those are the two important tumors that one should consider at this location. Of course, anatomical variants within the jugular bulb, like a dehiscence or a high-riding jugular bulb, also can show a bigger lesion, like a bigger jugular fossa, jugular foramen itself, but will not cause any mass-like morphology or enhancement on the MR or the post-contrast images. So the likely differential would be between a glomus jugular tumor or a schwannoma, and a third possibility of a metastasis. Metastasis usually can destroy, like what you are seeing here, of the bony walls, but these vascular flow voids are usually not seen. And then glomus jugular, of course, enlarged jugular bulb also will be enhancing because the jugular vein, but you exactly do not really see these vascular flow voids. Cholesteatoma is definitely unlikely in this case, simply because cholesteatoma is a lesion which usually happens within the mastoids, and they do not enhance. There is no real mass as such, an enhancing mass or vascularity within the lesion. It is a completely avascular lesion. So that is the least likely or most unlikely lesion at the skull base in the jugular foramen. And these tumors, just like the adrenal medulla, they have a common cell of origin in the neural crest. So these are neural crest cells, and that's why some of the glomus tumors, especially when they are multiple, like glomus jugular, glomus tympanicum, or a carotid body tumor, or bilaterality of the tumors, in these cases there is association with pheochromocytomas, and some of these lesions can also be functional, and just like a pheochromocytoma of the adrenal medulla, you can also have noradrenaline and patients present with hypertension. So the cell of origin is the neural crest cells for all these cases. And in the fifth case, a fifth patient is the best next step is to a definitive treatment is usually an excision in most of these cases. Moving on to case number 14. It's, I think, going to take another 5 minutes. Bear with me, and I'll try to finish these two cases as quickly as possible. The right lobe of the cerebellum is what you are seeing, a big cystic mass with a solid enhancing nodule within that lesion that you are seeing. And then in addition, he has got multiple other enhancing masses, all of them below the tentorium and also involving the upper cervical spine. So this is a multiple enhancing lesions, and classically with a cystic lesion with an eccentric nodule, and the diagnosis in this case is, as you can always imagine by now, it's a hemangioblastoma. The multiplicity of the lesions tell you that this is probably a VHL or a von Hippel-Lindau disease. They are always infratentorial, and the hemangioblastomas other than infratentorium, the only other location that you normally see them will be the orbit. The orbital hemangioblastomas are known, or retinal angiomas can also be seen. And there is, of course, other associated other system involvement can be there in the kidneys, liver, with cysts, RCC, and all those associated lesions in VHL. And the recurrence pretty high in these cases of hemangioblastomas, especially after the surgery of the tumor, and the increased number of tumors can appear not only in the upper cervical spine, but along the CSF pathways into the rest of the spine also there can be seeding of the tumors. So the postoperative recurrence is not low, it is very high in hemangioblastomas. Overall prognosis is good, but recurrence and morbidity is high. And the last question on this is the other tumors which can be there, which will show this CSF spread. The common ones are medulloblastoma and pinealloblastomas. Neurocytomas are the least frequently seen. They are septal tumors within the non-enhancing. They are not known to produce any CSF pathway spread at all, like a medulloblastoma, pinealloblastoma, or even plexus tumors. The last case we are coming to is an intraventricular enhancing mass with some degree of mass effect and midline shift, very early developing hydrocephalus on the right. And on the T2-weighted images, there is a significant drop of signal within the mass, and such an enhancing mass intraventricularly, as you can see by the thin rim of CSF fluid, tells you that this is within the ventricle, and of course it is showing significant edema surrounding it. This is an intraventricular meningioma. And other differential would be any intraventricular enhancing mass like a choroid plexus papilloma, ependymoma, and or even metastasis, though it's very rare to have intraventricular metastasis. So the most likely, especially given that the T2 signal is very low, this is a case of intraventricular meningioma. And I think we already talked about the low signal intensity on T2-weighted images in cases of meningioma and also lymphoma, which I mentioned earlier. This is the other one which shows a T2 signal drop because of the cell packing. And the last one is the degree of the rate of calcification in these cases of meningiomas is very low. Actually, it is less than 1/5. So in fact, a predominant number of meningiomas do not calcify. But when the calcification happens, it is typical, and it's very classical, the diagnostic. Thank you very much. If you have any questions, you can post it, and that ends the discussion.
Dr. B, thank you so much. Before you begin to answer the questions, please let me remind our attendees that tomorrow evening at 8 p.m. Eastern, we will be presenting MSK. Dr. B, have you had an opportunity to undock your question panel?
Oh, 1 second.
Prabhakar, would you rather that I cluster the questions and read them out to you and you can answer them? That way you have...
Sure. Okay.
Well, all right.
Go ahead.
Okay, so the first question is case 1, question 2. Why is this not a, why is the correct choice not B?
Question 2.
2.
Photon starvation? Photon starvation, yeah. The beam hardening artifacts are typically the horizontal. if it is a photon starvation, it will be everywhere. The artifacts will be everywhere. It will be lot of pixeling effect will be there throughout the image rather than right at the junction of the bone and the brain, especially at the petrous temporal bones. That's where the thickest part of the bone is, and because of that, this is a beam hardening because of the thick bone rather than a photon starvation. If it is a photon starvation, it will be more uniform throughout the image rather than confined adjacent to the posterior fossa.
Very good. Case 1, question 4. What excludes chondrosarcoma as the most likely choice?
I think I already talked about it, that it is where the important differential would be between metastasis and chordoma, but the chondrosarcoma should have calcifications. So the calcification or the absence of it is, I think, much more important. But a lot of times it may be very difficult to differentiate, no doubt about it, but absence of it is most important, or presence of it is important.
Okay. Would you, case 2, question 3.
Okay.
Would you see this finding in, would you see the same findings in GBM as well?
Yes. The 3 important differentials whenever you see a butterfly lesion with a non-homogeneous enhancement with cystic lesions and even with bleeds will be GBM, toxo, lymphoma. Everybody will talk about GBM and lymphoma, but please include toxo. It exactly looks like the other 2.
Great. Now, is the second part of that question is GBM common in patients with HIV as well?
No.
Or do these patients have the same incidence as general population?
It's a general population. It has no real relation with the HIV. The only 2 things which have relation is the toxo and lymphoma with HIV.
Thank you. Now, can you explain what you mean by heterogeneous enhancement in toxo in case 2? For example, is the lesion partially cystic, or can there be hemorrhage? That is more of a pathology as to what's going on in toxo.
There
Yeah,
can
that
be
question
hemorrhage. Hemorrhage is not as...
Go ahead.
As a active type of toxo. It's like tumor, and it has got some component in the tumor-like mass, just like a gene, and that gives that heterogeneity. Wherever there is cystic, there is no heterogeneity.
Okay. Now,
and the multiplicity is one important finding between the 2.
Okay.
Yeah.
Case 2. After case 2. Yeah, just show up the case 2 also, the image also, please. They're requesting that.
Yeah, case 2. Yeah.
Go to your, yeah. If you right-click on your PowerPoint screen, PowerPoint window.
Yeah, this is case 2. You're not seeing?
Okay. Mine is probably frozen. Ruth, can you see?
I am showing case 2 for images, case 2. That's what is on my screen here. That's what I'm showing.
Okay. Ruth, can you hear me?
So what is the question on this?
Okay, the question is, can you explain what you mean by, after MR imaging, next step is empiric treatment and follow-up or PET-CT? Or does this differ from institute to institute?
That probably differs, but the ideal way is to do an empirical treatment because there is no real emergency treatment that you need to do within a week or 2 for a lymphoma anyway. It's not going to change the overall prognosis. And PET not only takes time, it is very expensive. So an empirical treatment with toxo together with, of course, as I said, a PCR of the CSF or blood. Then if follow-up MR, if it doesn't show any resolution, because it is expected to show resolution within 2 weeks, and if it doesn't, then is the question, whether this is lymphoma and not a toxo. That's when you do a PET, and then you have a definitive diagnosis, and then treat it. Lymphoma.
Yeah, and then a very related question is, but toxoplasmosis is an infection also, so but it is not hot on PET?
No, it is not as intensely. See, the question is the typical lymphoma shows like a light bulb they describe on a PET, but the SUV values will be extremely high as opposed to a toxo or an infective lesion, which can be bright. It's not completely cold lesion, but the SUV values will be way, way, way below a lymphoma. Okay. See, on an example, if an SUV value of lymphoma is in the range of 9 to 10, a toxo will be in the range of 3 to 4 or 2 to 3. So there is a huge difference in the way they light up also. So that is pretty specific and diagnostic in these cases.
Okay, and then it's the same question asked by a couple of people. Case 4, question 5.
Yes,
can you say why this is early hydrocephalus? What are the clues on the actual image for early hydrocephalus in this question?
Case 4. See the way, yeah, case 4, okay.
Case 4, question 5.
See the atrium of the lateral ventricle and see the frontal horn of the lateral ventricle. How asymmetric it is to the compressed ventricle on the right side, and the size of the ventricle itself compared to the absence of sulci or anything. No doubt the images are not that great. This is a case which is probably about 12 or 13 years old. So the images are not great, but you can appreciate that there is complete, near complete absence or obliteration of the sulci, but at the same time you see that the ventricles are pretty big, especially compared to the right. So there is definite, you should suspect that there is a hydrocephalus. And again, because of the attenuation and compression of the ventricle, the site of obstruction even here is somewhere near probably the foramen of Monro itself, just like in a case of a subfalcine herniation.
Okay, and then there's a same thing, and I think it may just be case 4, question 5. Let's see the next image. Yeah, where it says question 5. Yeah, they're saying, how can we say there is mass effect when you are not showing us the brain windows? When you're showing us bone windows only. On the muscle mass on the brain can be added. Yeah, I think we just have to put that image. Yeah. That image
you
from
may have to put, but you have already seen that. You know.
Yeah.
You have seen it. It's a question. Maybe we can probably adjust the image, but there is no controversy as to whether there is hydrocephalus or not.
No, I think it's
maybe
just
I fully agree that this is not the appropriate image to look at the soft tissues or ventricles.
Yeah.
No doubt. So probably this question should have been when that other images is there. Yeah.
Right. Okay. Case 5, question 2. Case 5, question 2. Why is the answer A in that question 2? Why is the answer A? Case 5. Why is the answer not choice A? Why is the answer not choice A?
The absence of, the first thing is the epicenter of the lesion. The cholesterol granulomas are within the petrous bone rather than in the posterior fossa itself. Number 2, this is, though with contrast it is a T1 weighted image, it should be brighter for a cholesterol granuloma. So both those things will take the cholesterol granuloma out of the equation.
Okay. Case 6, question 5. It says, why is a sudden loss of vision more important than hemorrhage?
As I think when I said in the beginning itself, intracranial hemorrhage, you can treat it. It is not more important. When there is loss of vision, it is irreversible. And when the hemorrhage is there, the prognosis is definitely bad, is really bad, but it depends on the amount of hemorrhage and still can be managed, and the patient can come out without any neurological deficits. And the irreversibility of the vision and the importance, of course, of the vision itself would be the much more important between the two. But when I was discussing, I made sure that I did say very clearly that these are the two important things that one should remember, that it can be hemorrhage or loss of vision. But on a relative basis, because of the irreversibility, I think I will put vision loss as takes much more priority than hemorrhage. Because hemorrhage is variable. It can be a small bleed, big bleed, can still be managed without any consequent effects. But vision loss, that's the end of it. So.
Now, can you explain, that is now on case 7.
Case 7, what number? Question?
No question number. She says, can you explain, one moment, why cavernous hemangiomas do not generally enhance?
They are very hypo or avascular. So that's the reason where they are very occult lesions. Even when you do an angiogram, there is basically nothing that you see because the vascularity is so poor. So there are vessels enough to bleed. Yes, that is the important finding that you see all the time is hemosiderin because of bleeds. But at the same time, they are not vascular enough to cause positive enhancement or a significant enhancement, I would say. That's why the enhancement is described as minimal to none. And that's the reason why they are occult lesions, despite a very nice lesion like what you see in this case. Then if at all you go and do an angiogram, you see nothing as far as vascularity is concerned. So that's the reason.
So that also brings us to, why does embolization have no role in the management of cavernous hemangioma?
There is no vessels to see, as I already said.
Yeah.
It is absolutely said that when you do an angio, there you see nothing, absolutely nothing. It's called an occult lesion. So, so there is no question of any embolization at all.
Now, does have to involve the cortex to present with seizures?
More frequently, yes, but and not invariably, because in general the rule is if the cortical lesions come with seizures, the deep lesions come with neurological deficits. That's the general rule. So how deep, how cortical, it is very relative. So, yes.
Case 8, question 4.
There is a lag.
That's okay.
In case 8.
Is it freezing up? Yeah, let's just go to 4. Okay. Yeah, there, and your thing has changed
I
too.
get the image.
Yeah, it has changed.
Yeah.
Go to the image. It will keep on changing itself.
It does.
Okay. So that it says, can you point out the pyramidal lobe in this?
There is no thyroid gland. What I was showing is not the pyramidal lobe. What I was showing here is the absence of the normal thyroid tissue pretracheally that you expect normally to see, because the entire thyroid is sitting here at the base of the tongue. So there is no absence of thyroid is the thing. Pyramidal lobe is a question which is a question number 5 as to what is the inferior attachment of that thyroglossal duct, which is a pyramidal lobe. And I explained why it is called a pyramidal lobe and where it is.
Sure.
It is the left of the midline within the isthmus in a normal thyroid, which is pretracheal in location. That forms the thyroid lobe, pyramidal lobe, because of the attachment of the thyroglossal duct.
Okay, now case 9, question 2. Yeah. So 2 questions on this, and they are very very